Hi, Sam here, and I am submitting my video submission for our first assignment, which is the critical appraisal of the PROTECT 2 study on Impella. So, the appraisal of a randomized control trial is best conducted based on the template for the critical appraisal of RCTs, which was presented by Dr. Martin in lecture. So accordingly, I will appraise this trial according to her template. And the first question involved in that is, what is the research question being addressed in this study? In other words, what is the PCOS? So the answer to that is that the P, or the patients, basically are those deemed to require hemodynamic support during high-risk percutaneous coronary intervention, or PCI as I'm going to call it. Patients are very well defined in the methods section of this study, and inclusion and exclusion criteria are detailed further in the appendix, which is a positive as it's very specific and direct in terms of who they're looking at. The intervention, the I of PCOS, is treatment with Impella 2.5 percutaneous left ventricular assist device, or Impella as I'm going to call it. And the comparator, or the C, is intra-aortic balloon counter pulsation pump, or IABP, as I'm going to call it. Now, the O, or the outcomes, is one of the more interesting aspects of the PCOS. It's broken into two endpoints. The primary endpoints are the composite rate of intra and post-procedural major adverse events, or MAE, as I'm going to call them, at discharge or at 30-day follow-up, whichever was longer. Now, the MAEs are a list of 9 different aspects, which in my opinion is far too many, to be frank. And that's because at an alpha of 0.05, or 5% significance, the expectation is that investigators will have a 1 in 20 chance of finding a significant finding due to chance alone. Now, these MAEs total 9. However, many include subpoints. For example, stroke is included with TIA, CPR with tachycardia, etc. So that grows this list even longer, making it even more likely that investigators will find a significant effect when none exists in reality, which is called a type 1 or an alpha error. Additionally, although many of the MAEs are well defined throughout the paper, some are not and are more subjective. A good example of this is whether or not patients require surgery, cardiac surgery. This is highly subjective, and conditions for requiring such surgery is not well defined in an appendix or elsewhere, as far as I can see. Now, the second category of outcomes is the secondary endpoints, and this includes 90-day follow-up of the composite primary endpoints. So that's an important note as we go forward, that there are two aspects: primary, which is essentially 30 days, and secondary, which is 90 days, and that will become very relevant. So the S of the PCOS is the study design, which in this case is a randomized, non-blinded control trial. So the next question we want to ask ourselves is, are the results valid, or what is the internal validity of this study, in other words? This is a very broad question, so I'm going to start with, did the groups start the trial balanced? Now, to answer that question, I want to look at whether patients were randomly assigned to different treatment groups and whether that randomization was truly, indeed, random. Now, to address that, I noted that this study uses a stratified randomization design, which I think is good because it helps to ensure that baseline characteristics between groups are similar, in that they were stratified based on their geographic location, among others, but this will help control for the geographic differences. They were also randomized in a 1-to-1 ratio, which is good because it will make the sample size equal and the statistical analysis much easier. And the most important aspect is that they are randomized in a 1-to-1 ratio, which is good. Oh, sorry, I already said that. Randomized using a centralized phone number, which is good because this is a multi-centered study, and using a centralized randomization center will help reduce selection bias in that everyone will be randomized according to the exact same procedures, and there will be less likelihood of clinicians or assessors or investigators, for that matter, randomizing patients to different groups preferentially. Now, this randomization is useful for a few reasons. Mainly, on average, it helps ensure that confounding variables are controlled for, which is important because randomization helps control for both known as well as unknown confounders, rather. So the next question I want to ask myself is whether the randomization is concealed. And in this case it is, because neither patients nor investigators had any prior knowledge of which group the patient would be assigned to, which is a positive aspect. So the study gets a yes for the concealing of randomization, as well as whether a true randomization was done. The next aspect is whether they did an intention to treat analysis, which basically means that patients are assessed based on which treatment group they were assigned to, rather than a per protocol analysis, which is where patients are assigned based on the treatment they truly received. So an intent to treat analysis is done and is reported frequently throughout the discussion and conclusions, which is a positive aspect. And the final question here is whether the baseline characteristics are similar. And that's a question related to the Table 1. So based on the data presented there, the baseline characteristics seem very similar. This is based on the fact that there is only one significant p-value in terms of a difference between the Impella and the IABP arm, and this is in the history of congestive heart failure. But because there are 15 characteristics in this table, it's not unreasonable to think that one of these characteristics may be significant due to chance alone at an alpha of 5%. Because of this, the fact that randomization should not be deviated from to correct this is a positive aspect, that they didn't do that, and the baseline characteristics can be deemed similar. So I give this study a yes for whether or not patients started out balanced. Which leads me to the next issue of whether groups remained balanced after the study started. So the first question related to this is whether this study employed blinded allocation as well as blinded ascertainment of outcomes. So the first group I want to look at is clinician blinding. In this study, it can't be reasonably expected that clinicians would be blind to the treatment, because surgeons would be required to have a knowledge of which procedure they were performing beforehand. So although an unintended consequence of this is that the use of Impella 2.5 was found to be associated with more aggressive use of rotational atherectomy, this unfortunately may be unavoidable. But this paper wasn't very specific in terms of whether patients and assessors were blind. So I looked up this study on the clinical trials registration database, clinicaltrials.gov, and it designated this study as employing an open label type of blinding. This means that no parties involved have been blinded as to the allocation of treatment. Now, I'm slightly concerned about this because, especially since assessors were not blinded, I see this as an opportunity to introduce information bias into the study. And what I mean by that is, because assessors of outcomes would know whether patients received Impella or IABP, they might be preferentially looking for outcomes in one group versus another. So I give this study a no in terms of blinding and allocation, despite the fact that it's not possible for all cases. They definitely could have blinded the patients as well as the assessors. So, was follow-up complete? That's an important aspect to address, and the Data and Safety Monitoring Board, or the DSMB, recommended that this study be ended early based on interim data. Now, this is problematic for two reasons. First, according to the study limitations section, there was a significant learning curve associated with this study, and this may have been overcome had the study been allowed to continue, which may have altered the results they saw. But the second issue is that the DSMB was allowed multiple looks at the data on an interim basis. Now, this is problematic given that this study lacked a spending function, as we discussed in lecture. Randomized controlled trial procedures dictate that for every interim look at the data, the spending alpha needs to be adjusted accordingly. For example, if there's one interim look, an alpha of 5% would become 2.5%, etc. The intention of this is to accommodate for the fact that multiple looks at the data can inflate false positives, or alpha errors. Although the spending function corrects for this, and even though the PROTECT2 DSMB took multiple looks at the data, they did not apply a spending function, which is concerning. This, especially in combination with the multiple primary endpoints, greatly increases the fact that they will find something significant purely due to chance and not, in fact, due to genuine differences between Impella and IABP group. So I want to move on now from description to look at whether these results are important. So what is the magnitude and the precision of the effect? Now, both the intention to treat, or the ITT, and the per protocol analysis are both done, and there is still no significant outcomes in the primary endpoint of interest, which is the composite MAE at 30 days. Now, the ITT analysis is more important as it reduces the effect of dropouts and crossover. Only looking at MAEs for 30 days, which is the area of importance in that it was the primary endpoint, there was one MAE that was significant, stroke or TIA. This is based on Table 3, where the ITT results are presented. However, it's important to note that with so many MAEs being looked at, this could definitely have been due to chance. Additionally, it's unclear because it includes two outcomes, stroke and TIA are both lumped together. This further increases the chance that investigators would find something significant. The per protocol analysis is less meaningful than the ITT because it loses the benefits of randomization. And what I mean by that is that if it were to find a higher treatment effect, that may in reality be due to the characteristics that caused the patient to deviate from the protocol and to switch arms, rather than a treatment effect that was actually due to a difference in the treatments. So regardless of this, though, even in the per protocol analysis, few significant findings are found at 30 days. But there are statistically significant findings at 90 days, which was, as I mentioned, a secondary endpoint. But since this is not a primary endpoint, it's not of particular interest to this particular study, although it's mentioned numerous times throughout the discussion and in the conclusion. But that's a spin issue, which is different. So the clinical trial registration of this study indicates that this is a phase 3. In light of significant findings at 90 days, I think that a phase 4 study should be recommended. In this phase 4, the investigators can then look at whether 90-day outcomes are significant when 90 days is in fact the primary endpoint. And the justification for this phase 4 additional study can be based on the current PROTECT 2 phase 3. So the next thing I want to look at is whether the results are applicable, and this is an issue of external validity. And the question related to this is there a good reason to say that these results do or do not apply to the patients that they're looking to be applied to? Now, I see no particular reason to question the external validity of this study. Based on Table 1, the age distribution and characteristics of the population seem reasonable, given that Impella is intended to treat PCI. However, this paper does not specify whether patients were randomly sampled for this study, which is problematic because it may affect the generalizability, and it wasn't clearly laid out how specifically they went about selecting patients as participants. Overall, I think the study can be concluded to be relevant to some clinical populations, although the question of whether the study is generalizable to a specific population depends on how the characteristics compare with the characteristics in the Table 1 of this study. So a possibility here is running a quick analysis maybe to determine if they're statistically significantly different, and that would indicate the less different they are, the more likely it is that it's going to be applicable. So the last question I want to address, and what I think is the most important question, are the results worth it? In other words, are the benefits of Impella worth the risks and the costs? I think it's important to note that this study was two-tailed. This is important because it would not only find whether Impella worked better than IABP, but also whether it did any significant harm. So given that there was no significant finding in either direction, I can't conclude that there were any significant harms associated with Impella, just like I can't conclude that there are significant benefits. But given the lack of phase 4 follow-up, and given the consequent uncertainty of the long-term effects of using Impella, I'm going to alter this question, not to whether Impella's benefits are worth the risks, but instead whether Impella's use is worth the uncertainty. And based on this question, my conclusion is that until Phase 4 follow-up trials are conducted, the use of Impella is not worth the uncertainty, and the use of IABP should be continued. So thank you very much, and my references are available in the Dropbox of our course website. So thank you for listening, and I will see you next week.